So, hello everyone, and warm welcome to this webinar on health workforce dynamics life cycle approach. This is one of the most interesting topic of our Global Rural Health Summit. And as you all know that we have already drafted the paper and paper is already there in our group. And before we begin the discussion, we'll just have a round of introduction. And I'm Dr. Pratyush Kumar. I'm the chair of Wonka Rural South Asia and the chair-elect of Rural Wonka and the convener of this Global Rural Health Summit. Christos.
Thank you very much, Dr. Kumar. Christos Leon is Professor Emeritus of General Practice Primary Care and currently the chairman of the Vonka Working Party on Mental Health. Thank you.
Harini.
Hi, I'm Harini. I'm based in the University of Saskatchewan. I'm from the Department of Community Health and Epidemiology. So my research focuses around medical education and social accountability in health systems.
Thank you. Canon.
Hello to all. I'm a family medicine specialist and lecturer in family medicine department in Turkey, and also new elected in Wonka Rural Secretary. Thank you.
Thank you. Devanto.
Hello, I'm Dewanto. I'm a family physician from Bandar Lampung, Indonesia, and also currently in a specialist program in Universitas Pelita Harapan, Indonesia. I'm also involved in a MDD Minds project with Prof. Christos here from the Wonka Working Party for Mental Health. Thank you.
Thank you. Gobit.
Hello everyone. This is Gobit from Sri Lanka. I'm a rural physician and academic from the National Medical Faculty. Happy to be part of here. Thank you.
Thank you. Darshana.
A very good evening. Apologies, my camera isn't working. I am a family physician from India, Mumbai. I practice in Mumbai, and I have recently completed my master's in international health as well. So looking at health on a broader perspective now. Thank you.
Thank you. Dr. Anshu.
Hello, everybody. I am Anshu. I am a professor of pathology from the Mahatma Gandhi Institute of Medical Sciences at Sevagram. This is a community medical school in central India, and I have a special interest in medical education. I'm here representing the Network Towards Unity for Health as its South Asia representative and on the board of directors there. Thank you.
Thank you. Ram Prasad. Ram Prasad, can you hear us? Okay. Ayatrik Das.
Good evening, everybody.
Delay, sir. I am Dr. Ram Prasad,
Okay.
family medicine specialist from Nalgonda, Telangana. I did my NBEMS Diploma of Family Medicine from Rajasthan. Thank you.
Welcome. Welcome. Ayatrik.
Good evening, everybody. I'm Dr. Orithrik. I'm from the community medicine side of things. I'm currently a senior resident in PGI Chandigarh. I'm mostly working on the paper on optimizing the workforce as well as the resource allocation. But I just thought I'd listen to what we're discussing here as well.
Thank you. Thank you. Darshan Patil.
Good afternoon, everyone. I'm Darshan Patil. I'm studying as a final year MBBS student from Allahabad Medical College.
Welcome. Welcome. Miriam.
Hi everyone, I'm Miriam Dolan. I work in as a general practitioner in rural Ireland, Northern Ireland to be precise. I'm also a member of the executive committee of URIPA and the scientific board. So that's why I'm here.
Welcome. Tabinda.
Hi, good evening, everybody. So this is Tabinda. I am a family physician working in South Asia, Karachi, Pakistan. So I'm also the convener for MRCGP International South Asia exam. I'm working with this. I have done some work in this paper, and I was also contributing to some extent in the other optimizing healthcare. Primary healthcare resource allocation and dynamics of the healthcare system and everything. This seems a little bit interesting topic for me since always been. I've been involved to a certain extent. I've been involved with some kind of grants with WHO for the healthcare system thing. So that's why I thought that it's always interesting to learn from the colleagues all over the world. Thank you.
Thank you. Itash Dwarka.
Good evening, everyone. My name is Itash Dwarka. I'm currently a medical student in Kasturba Medical College, Manipal, which is from South India.
Welcome. So we'll begin this webinar with a basic introduction, and I'd like to invite the authors of this draft paper. Can I start with Harini? Can you give just a brief introduction, and then we'll move ahead with the paper. Okay.
Sure. So the main objective of this paper would be to discuss how we could use a life cycle approach and for retention and looking at retention of health workforce, particularly within a rural or remote setting, or resource like denied settings across the world. So I think there has been a focus on the global south and how we've written it up, particularly the divide between in countries where there's a very stark rural and urban divide. So we kind of get into the limitations and challenges of how we could how that are preventing that retention piece there. And so I'll also kind of get into how there's that urban rural divide and how a lot of different systems do not incentivize retention within rural areas. And so we see most people, even within certain countries, being in the urban centers, and examples of India, Pakistan. And then there's also the global divide, in which we see a lot of the brain drain or the migration of these of our workforce to countries of the global north, which is in the promise of better prospects. So people are incentivized with a lot of those promises. It's not to say that those countries don't have the same problems, they just have it, but it's that it's been incentivized in a certain way. So workforce has been draining. So we're looking to see how, from the very inception itself, like from medical education, how can we build in that reciprocal, like community relationship piece where people are forming meaningful relationships with communities. They find value to staying in low resource settings and working with communities and advocating on their behalf there. And also how they can then be, they can also be receiving the support and all the benefits as a practitioner. How can they have a fulfilling career working in those settings? So I think that's what we're trying to build and present here. And I look to the other authors to take it forward.
Thank you. I think you just summarized it beautifully. Like, this topic is basically, if we divide into some four subgroups, it starts from the education, where a doctor, nurse goes into education, and that's the training part. Then comes the recruitment part, where is recruited, then the retention, and sometimes in between there's also some kind of migration is there. There are other components too, like equity, which she has rightly pointed out. The divide between global north and global south divide is there. These are some of the important issues, like, which we have to write the paper, is there in the paper. Uh, I'll invite others to just comment. Tabinda, can you just focus on some aspects of this paper?
Yeah, so like we said that there is a lot of migration and we are talking a lot about the Pakistan and India, but it's there. I think it's almost there in many developing countries, because in Sri Lanka also we have seen the same kind of situation is there. Even in Bangladesh, there is a lot of things similar kind. So that's what we have been trying to build in that paper. Next thing, the other issue was, like we said, about the community engagement. So involving the community, which has also come into the paper, that we involve the community so that they can contribute in a better way. Like I'll give you an example of current situation, which may be, so there is a place called Balochistan, one of the province of Pakistan, right? So what is happening there was that because of the law and order situation, nobody is willing to go to that place despite of giving them high salaries, and a lot of people were denying. So what they did was that they approached the local community. They were hired there as a, they were qualified people who were hired there, and but still there are problems going on. Why? Because of the many issues, like despite of them that they are qualified, they are not something like, you know, they're not updated with recent guidelines and things going on. So there is a remote kind of supervision being done, so that is still creating problems. So that's one thing. The other thing is, like Harini said about the incentive. So a lot of people, I would say, from the developing countries are moving to the developed countries, a lot going to the Emro region or UAE or Abu Dhabi and Dubai, where they are getting good salaries. That is one of the main reason, and a lot of people are
I think your voice is not audible. Okay. We'll move on to Christos. Your views on this.
Yes, thank you very much. First, another time expressing my gratitude. I'm thinking that is an excellent paper, and I have a few comments. First of all, since especially this topic addressing all geographical regions, not only Asia, I think that is very important, included the country cases from all the regions. Initially, I was thinking that potentially we have one theoretical model in explaining more the migration, brain drain. And now, just a couple of minutes ago, after looking at the paper, identifying, and congratulations again from fantastic contributors, one important paragraph in the place where accountable factors explaining the migration could start to discuss and identify one paragraph, fantastic personal factors. And those personal factors, to my view, completely different when in comparing isolated in the rural areas in Europe with Asia or South Asia or in other regions. And I'm not certain if we're having a theoretical model in explaining. For instance, it's not only the financial reasons that they giving and removing the doctors from one country to the other. It's also many other that's responding to the personal characteristics, values, and preferences. And I'm thinking that we needed a little bit giving a more focus on regional variations. And I think that needed to stress what exactly we mean in personal. I put in a comment on that, but for myself, it is one of the key issues of the paper, because a such position paper is not only just a little bit reporting and just describing what happening and trying a little bit to explain, but also just to recommend. Recommendation is very much important, and potentially for the stakeholders and the policymakers. And if we just, for instance, concluding, because that is a position paper, means consensus, that different models indicate or explaining the migration phenomenon across the regions, and just a little bit making more concrete and explicit suggestions what needed to address in a specific parts where isolated and rural physicians. I think that, to my personal view, is the added value of this paper. Thank you very much.
Thank you. Thank you. Tavinda would like to finish something which you wanted to speak. Can you unmute? Unmute. Please unmute yourself.
Yeah. So I don't know where I got disconnected. Suddenly it got disconnected. I was just saying that we are trying. I was just listening to Christos. So very good point. Apart from what he said about that the financial issue and everything else, one major concern I think South Asia has is the political influence also. That is one of the major concern which we have, and the safety that is there, which is forcing people to migrate. That is there. So that is somehow not been addressed in the paper. So that I think we need to somehow. That's it. Thank you.
Thank you. Dr. Anshu would like to speak.
Yeah, I agree with what Christos said about the personal factors, because that is one of the important issues which we talk about in selection of medical students. There are examples in literature which say that students who are recruited from rural areas have the tendency to go back and work in the rural areas. So that's one thing we have not quoted. I think there is one line somewhere, but we can expand on that and use some examples or case studies of that part. As of now, while the paper itself has a lot of examples from all over the world, in the abstract, when you read it, it looks like it's coming from the Indian subcontinent. So I want a little slight tweaking of the abstract so that it looks a little more global there. The other thing is what Tabinda just said, where with the abstract that you just shared now, Pratyush, there is a whole section where we are talking about the reasons for migration. And we have talked about economic pressures, political instability, conflict, corruption, and restrictive policies. We've talked about better approaches to career development and how some countries actively recruit graduates from the Indian subcontinent. So those are things which are happening and they have found a place. If we can give specific solutions in one section, I think it will make a paper a little more robust, like 1, 2, 3, 4, 5, you put bulleted points and say, these are the recommendations to retain. As of now, the case studies are there. The Indonesian example is taking a lot of more space, but somehow at the end of it, if somebody is reading, I want the recommendations to come out a little more stronger. Thank you.
I think in the draft format which I've shared long back, the last column is for the recommendations only. Anyway, we have time because during the summit also we'll take suggestions and we'll include that in the final paper. But anyway, if we have got the columns for the recommendations at the end, then it will be much easier for us to edit. And we'll go to Canon 2s.
First of all, thank you for this nice community that we are talking and chatting about. And thank you, Christos. I was going to ask the brain drain part if this topic should be included in life cycle of rural or not, but you already talked about it and I got the answer. Thank you for this support. Also, I was going to mention about the medical education part. I know we have some undergraduate medical students in the meeting, and also we have some colleagues interested in medical education. In medical education, we have AME guidelines, which are very popular and which are like medical education textbook internationally. And in AME guidelines number 47, they say that country-based medicine and undergraduate medical students' rural experiences impact on the rural health services. So I suggest that we need to emphasize the need of undergraduate medical students' rural practices. And the second point I was going to say, thank you, Dr. Anshu. I don't know if I pronounce it wrong or not. I already prepared the abstract and the conclusion part, but before the recommendations, and I didn't have any time to renew it. After this meeting, I will try to make it more better and perfect by the help of your recommendations. Thank you.
Thank you. We have got some young medical students. Will also take their views. Itash Dwarika or Ram Prasad would like to speak something on this topic.
Yeah, so I agree with a lot of what's being said, especially that that it's very important to discuss like politically why the political factors of it. Because me right now as a student here, there is like a lot of reasons why I would want to stay in this country or not. Let's stay or go like to the go to countries more developed countries. So I think that is a big factor. And otherwise, I agree completely that like the rural experiences of medical students play a big factor on whether they want to go serve in a place or not. And India, at least as a country, I feel like our government has done a good thing because we have something called a bond. So after I finish my MBBS, if I'm from a government college, I need to go serve 1 year in a rural area as a kind of give back to the community. So I feel, especially at that point, that is what makes a big impact on whether a student is going to want to stay here or go somewhere else.
Okay. Okay. And do you think that these bonds positively influence a person, a doctor, towards rural practice, or is it negatively influenced away from the rural practice?
I would say, see, looking at it right now, while I'm still doing my MBBS, if I was from a government college, I would say definitely it is like, why do I have to go serve? But as you go see the thing at the ground level and look at the people, I would definitely say that has a huge positive impact of like saying, yes, these people actually truly need it, right? It's not some huge urban place where like, oh, everywhere there is this.
Right, right. And that's the immersive kind of training we need more often in medical colleges, so that early during the training, if they are exposed to rural areas, no, if they see it firsthand, then there are much more chances of retention in rural areas. Miriam would like to comment on this.
Just a few notes that I made,
Yeah.
following this discussion. So yeah, see the personal factors. Like there was a paper done or research done by our Czech colleagues in rural Czech Republic, and they found it was actually the personal factors that really keeps people like GP trainees in rural areas. So the career opportunities for their partners, childcare, things like that. The other thing I wrote down is that like Northern Ireland is of course part of the UK, and I know that 50% of GP trainees are international medical graduates. So it's almost like a global issue. Like the health services in the UK are totally reliant on international medical graduates. So it's definitely more like these are kind of almost like a global approach because there is a brain drain. The UK services will not, health services will not survive without the international medical graduates. The other one is more about the community. Like I practice in an area we can't recruit and we can't retain. And it was actually so bad that our community turned against us. And they put posters on our health center and we're not fit for purpose. So it's so extremely important, isn't it, that the community also understands what the issues are and that they support us to recruit and to retain, because when they turn against us, or you don't really want, it's also to do with safety and with almost moral injury, because you can't really deliver the service that you want, and then your community turns against you, so then you definitely can't recruit anymore. So that were just a few things that I wanted to contribute.
Right. Like brain drain is good for some places. It works because there are lack of well-trained doctors and even the population. But here we are talking about I think there was some technical issue with Zoom. I think it locked everyone else out of this webinar. So let's come back to the topic regarding the brain drain, which we're talking about. This brain drain is basically, from our perspective, which is very densely populated, and in some countries, which is very sparsely populated areas, how it's affecting. And if you look at also the doctor and the population ratio, and then there's a lot more things. It's not very easy topic. Brain drain itself could be a background paper for us to write for the next summit. Anyway, let's talk. Let's involve some other people like Gobit. Let's talk something about regarding Sri Lanka. What's happening there in Sri Lanka regarding the education part and the
Yes, actually, I can add one more thing. Like, even though from Sri Lanka, actually we have like same rural rotation. Yeah, I can. Yes. Then even for we have a rural rotation, so they will have chance with the rural 4 weeks, and that also has impact on some people are even interested to be in there. More than that, actually, the first appointment, soon after internship, they will get the posting according to their merit rank. So even though there's a non-rural fellow has to go according to their rank to the rural areas. From that, we have noted around 30% are willing to continue in their rural villages, that the same places, because they have familiar with the community, and also there's a need of that. So one of that, maybe this even it is like a forcefully they are going according to the rank, but still they have some sort of influence to their even the 30% is a bit good number. So that's one is there, and incentive it is there, because normally the ministry trying to give accommodations. Normally, even other area, maybe even the cities, they may have the difficulty to have the accommodation because of the very crowded places and all. But in the rural, there are plenty of places, so they try to give the accommodation and some other incentives in the way, maybe the allowance and all. That's maybe some to attract and all. And one more thing for my personal things, because I have brought it, I have born and brought it in the rural area. So because of my parents have to move it for their work. So because of that, I have had the passion to be there. Actually, our original houses are in the nearby the urban setting. But though we have moved it there my parents are moving there. So that's impact. Like even not only me, I have seen there are several my colleagues are there, even so they are brought up in the rural area, and they become a then rural physician in there, like. So that's also one of things, as we all talk about the brain drain is that happening because of we had a huge economic crisis, and after that everyone wanted to go there, but still we survive because we have like maybe dedicated rural doctors are there, like not only rural doctors, even the other healthcare workers, especially this and yeah, the community participation and things are also very important, because the if you had a good community support and all to run the event. So most of the things, our rural centers are one-man stations. One man means one medical officer station. So difficult to handle, even though, but even though they part of the community, if they go there, they are the leader of that community. So they automatically become a like this a likable place for them. So that's a one of thing. And yeah, and also for the shortage, we have some community health workers from the same village. We have got some arrangement with some other way, public-private partnership things and going on. I can add this. Thank you.
Thank you. Miriam, I'll just come back to you regarding the international medical graduates which you're talking about. uh, regarding the retention and the recruitment, like do they receive the same salary and the same services and same perks as the local doctors? Miriam Dolan? Um,
Okay.
yeah, it's all the same.
All the same. Yeah.
Okay,
Yeah.
yeah. Um,
But of course, salaries are higher,
uh,
and yeah, it's attractive. So compared to southern part of the globe, so
right,
attracts. But the health services in the UK are totally dependent on international medical graduates. 50%
and
of our GP trainees are
right,
international
right.
medical graduates. Yeah.
And how they engage with the community, because they come from different background. And like, do you all have workshops or some kind of refresher program for them to engage with the community, to understand the culture?
We do. The problem is, of course, you also can put down where you want to do your training, and often that people do prefer to be in urban areas.
Okay.
Yeah.
So urban is much more of a mixed
Yeah, more
population.
attractive.
Yeah.
More attractive. Yeah.
Okay. Christos?
Already, I put a comment on the manuscript. I think in that, of course, another factor is related to medical training, but not just only providing skills, but also satisfaction. I'm thinking that compassion and satisfaction with justice is a very key element in rewarding the physicians still lacking. Compassion has been discussed quite lastly in Europe. And I'm thinking that giving such rewards, we needed in thinking what type of rewards, of motives, because in general, migration could be explained or recognized entirely based on the theory of motivation. I think that is motivation related mostly issue, and needed to discuss what type of motives on reward, because nobody ignoring the so-called rewarding system in the central nervous system that's at least mobilized the behavior. And I think that we needed a little bit started thinking even in neurophysiological aspect and in explaining also migration, because it's an issue of rewards and potentially lack of motives. Thank you.
Okay. First Itas, then Tabinda.
So I feel like in places like UK, with the aging population, especially because it's a more developed country, as we see more developed countries, they tend to have a more aging population. So I feel like that 50% of the doctors that they need as immigrants, there is no real solution to that, right? Or like what could be possible ways to approach that?
That is so true. Yeah, that's so true.
I think there are lots more to do regarding if we talk about the global health, no, where we talk whole world as one family, then we can justify this brain drain to some extent. But if we look at the population density and equitability, if we put the equity in place, no, then we feel that those who are there in rural and remote population, because even our rural population in our subcontinent is very different from rural population in Ireland, because there we see few places, few houses. Here we see our rural population and much more than the country whole population of many European countries. And
Huh.
that's the issue regarding our health workforce. If you look at our nurses, they serve like whole world. The nurses from India, they are there in UAE. They you name the country and you'll find nurses from India
Yeah.
serve the population. Uh, Regarding doctors, also we have started producing lots of doctors. They have been concerned that we are producing lots of doctors like engineers. If you'll throw a stone, it will fall on some incorrect place. So there have been discussion like that. If we are increasing that number of seats, like earlier days, mentor-mentee, there used to be some kind of ratio that each mentor will train 5 doctors. So there was some issue regarding the how many numbers we are producing as doctors. But now if we have increased the number of trainees, then it also might affect the quality of training. That's also a consideration we have to put into place in understanding the whole issue. I'll bring Tabinda, your views on this.
Yeah, before this issue, I just wanted to say about the brain drain thing. So one thing which I was seeing is that there is so a lot of time, if you talk about people who have been trained, either they are the postgraduate trainees or the doctors, they have, apart from the financial issue, there is another major concern is that they say that there is no career progression in the rural areas. They just get stagnant. So they are not progressing in their careers. So that is one thing. So after COVID, there are a lot of online things going on. Online, am I audible? I'm sorry.
Yeah.
So there's
Yes.
yeah. So there are a lot of online things going on. So that may give them an incentive that they'll get progression in their careers in some one way or the other through some blended learning courses. One thing. The other thing is there is an Iranian study. So if you see the Iranian primary healthcare model, what they do is that they are giving incentives in forms of, so their GP is responsible for the local territory, so which is there is a certain territory which they have to be responsible. So if the indicators are improved in that particular area, they get incentive based on those improvement in the indicator that help to boost them their care. Some one way or the other they're accountable also, but they're also getting incentives. So say for example, if there are number of dengue cases in their particular territory which they are responsible, that gets improved through many ways: awareness, education, prevention. So they get incentive based on that. Iranian model of primary healthcare works through that. The other second thing which you said about the training, so I agree with you that previously same is with us also. So we used to have less number of medical institutes, universities, trainees. Now the number is increasing. Despite of that, we see that a lot of time this issue comes that we are training or making medical students just for going abroad. So we are just training them and they are leaving abroad. So that is one thing. And of course, the quality also has gone down because of the mentee-mentor ratio there is a huge difference. I can give you an example. There is a place called Islamabad. If you have heard about that place so this is one of the up north area, which is the capital of Pakistan, in fact. So it only that small capital area at this time has 10 medical colleges. So imagine the 100 seats, at least 100, that can extend to 150 or 200, depending on the licensing body permission. So imagine only that smaller places, buildings, giving so many medical graduates, and they are all going abroad. If you see the indicators, same is with the nursing, the healthcare professional, the allied healthcare, the same thing. Because of so there was one debate a long time back. I was attending a meeting where we were talking about how do you motivate. So there was one thing that if you can adopt a BHU, a basic health unit adoption is done by a university, so that will give a certain kind of flavor to the medical students. They'll get that flavor also, and they may get motivated to and similarly the adoption will improve the at least the primary health care on that particular area. So university will assign the medical officers, or the faculty, they have to go there, the medical students will be going, and ultimately you can serve many purposes through that. Thank you.
Thank you. Devanto would like to speak.
Oh yeah. So human nature and ambition of different generation, or in cultural factors and also emotional ties may play a major part in healthcare worker dynamics, I think. So as the title of this manuscript, the life cycle approach, we can also see that different generations have different views on working in rural areas. Yeah, so if we remember that when we are young, a medical student, sometimes we still want to have ambition, like go somewhere better, have better salaries, move to a bigger city and such. Even when people, when I remember some of my colleagues coming from very rural province in Indonesia, only 50% of them went back to their province. Well, luckily they went back, while the rest stay in the city. Well, you can't stop that because it's human nature, because people desire for improvement, to seek better living conditions, professional growth, and also enhance quality of life, and often seek opportunities abroad. Luckily for Indonesia, we are not very famous for speaking English, unlike Malaysia, Philippines, India, or Pakistan, who had a British or US occupation in their history. So mostly go to the city and not abroad. And then the education and skills also is important, because younger generation would still want to be trained and improve themselves, while in the rural areas, maybe they can't do that. Also, the cultural factors, such as what me and Anthony Sunjaya already mentioned in the manuscript, the community values in Indonesia. Healthcare workers may feel a strong sense of duty to their communities. These culture norms often emphasize family, community, and also a social responsibility that motivates the community health workers to stay and contribute in their rural areas. And also the cultural identity, deep connection to the cultural practice and tradition can also foster a desire for people to remain in the hometown or in rural areas. And the healthcare worker may wish to provide culturally sensitive care that often aligns with the local beliefs and also practices. Also emotional ties, yeah. Maybe people have a sense of belongingness to the rural areas. So that's why maybe the attraction of our scholarship for rural medical students is important in every nation in the world. I think that's from me. Thank you.
Thank you. I think you just introduced very new thing to us, like the nature, ambition, emotion, and the cultural aspect. These things I think should be the part of the paper. Have you like put that in the paper or not?
No, not yet. Maybe I can try and put
Uh,
that.
I think you can just put a paragraph about these things, because these are some of the factors which do influence, I believe, the migration, the retention of doctors, and these are some of the very important things. I'll bring in Dr. Ejaz Khan. Dr.
Yeah,
Ejaz?
thank you. Yeah, thank you very much, Pratush. When the last meeting that we had, in that I gave the example of how Iran has implemented a very strong primary healthcare system in their country, and their indicators are far ahead of us. Rest of the countries like India, Bangladesh, and Pakistan and Nepal. One thing I think we are missing here is the South collaboration, where the Center of Excellence in the countries of the Global South, they have the collaborations and they have the exchange programs and the high class of trainings being offered by those different centers. And one thing which is the other thing which is missing is the local guidelines and the research in the local diseases. So our students, they learn throughout their medical profession whatever is in the British literature or the British guidelines or American guidelines. So they develop a very less connect with the local kind of patterns and local literature and all these things. So one thing perhaps we can discuss is developing or considering to develop the South-South collaboration and the training exchange programs. And secondly, to invest in the research and development of the local guidelines and local aspect of disease pattern, which of course, which is more towards like prevention in the rural areas to prevent the non-communicable disease burden, which is rapidly coming up, and also in the cities and urban and semi-urban, because our problems are different from the West, and we are not focusing on in our medical literature. It is less focused on that, because it is more on the curative side and less on the preventive side, or the blend of it, which is required because we not only have the communicable disease burden, but also the non-communicable disease burden. And this mix, along with the air pollution and water pollution and all the environmental factors are also there, which are not there in the US or the UK or other Western countries. They have already controlled those factors perhaps a century ago. So we have that huge burden. So our medical curricula and the teaching methodology should also be geared toward that. And that would, I think, that will motivate and bring in the sense of ownership of the within the medical students, and some maybe some proportion of those tend to stay back and invest in their own countries. And secondly, of course, we have to try such models in which the incentives to work in the rural areas with responsibilities beyond just providing the medical care are there, and those incentives can be discussed, whether they are going to be the career progression or high pay scales or some other incentive which could retain them. Thank you.
Thank you. Dr. Anshu?
Yeah, I'd like to add to what Devant just said. We run a community immersion program for all our students. Now, I've often asked our students why, after all this exposure, they do not go back and serve in the rural areas. Now, they say that when our peers in the cities, when students in the cities measure success in the form of whether they're specialized or super specialized, when anybody going to rural areas is not considered successful. So the peer pressure to be like a doctor practicing in a metropolitan city, is that person is considered successful. It's how society looks at you. So the prestige is not the same for a student who works in a rural area as compared to somebody working in a corporate hospital. So things like that, the way society sees it, makes a huge difference to the dreams of the students. That's something I wanted to add to that paper.
Thank you. I think that's one of the more important issues. That's why there is some kind of rural-urban divide is there. Because medical students are not being exposed. Even they're exposed, there is some kind of peer pressure which is keeping them away from the rural areas. I'll bring Canon. Do you want to speak on this?
Actually, I was going to ask a question to you, Pratush. Actually, we're doing a great work today in here, and almost our draft is changing, but we only have 3,000 words. So if we add more topics, do you know any other common subtopics for the other groups, so we can move back from the draft, or maybe I don't know, maybe we can split the brain drain and write it separately as another topic. I don't know, what do you think?
I think like we have got another topic on global health is there. Then there's another topic on health workforce. There's another one on resources are there. That can also cover the brain drain part in that also. I think that's also the part of their manuscript also. So anyway, we can keep brain drain in this paper also, because anyone who will be reading this paper as a full paper may not refer to another papers. So this papers should have all the ingredients of this topic. We may keep it brief, but we should touch all the areas. 3,000 words, I think, is more than enough, because people also need, they have also, most of the people have got very short attention time. So if we can cover most of these areas, and especially the bullet points, the headings should have the major themes covered, then obviously we are free to go. And I'd like to invite, yeah, Christos.
No, just asking, what journal do you have already decided to submit? It's any
This is the Journal of Surgical Specialty and Rural Practice. This is one which we are going to submit
for
it.
all the position papers,
For
or
all
for
the
that?
position, all
Okay.
position papers are submitted in that.
Okay, thank
And
you.
also, our Bengaluru declaration will also be publishing in the same journal.
Okay, thank you very much. Thank you.
Thank you. Thank you. And we also have, like many other members, Dr. Darshana Salve would like to speak on these things. You have.
Yes, sir, everything is, I think, covered. But I do agree. I do practice in urban area, but when I was doing my internship, the main problem that we had, even we had rural postings, and we saw there were not a lot of facilities, to stay there, especially for the female candidates. Apart from that, remuneration plays an important role, but along with that, personal development, career growth, these are also some of the major factors which will make a doctor and individual stay back or explore for, greener pasture. So
Okay.
yeah. So I think that would be one. Thank you.
Darshan Patil would like to have your views on this. Darshan Patil or Yashashvi K. Okay. Anyway, we are just at the end of this webinar, and at the end, I'll just like to have your views on possible solutions. Just brief 1 or 2 points, and then we'll close this webinar. I'll start with Christos, and then we'll move ahead.
I'm very satisfied, and a very global approach is much impact. Thank you very much. Truly appreciate. Thank you.
Atavinda, your solutions for this health workforce dynamics, including the migration and everything.
I think most of the things have been covered, but like few of the areas which we have identified that could be added. One thing which I thought was maybe AI. How can AI help us in solving these issues? Nowadays, there is a lot of things going on related to AI. So that is something which we should add 1 or 2 points. So at something AI strategies needs to be added. Otherwise, most of things are covered. Thank you.
I think we have another topic on climate change, urbanization, and future of rural health, and that will have this all digital health, machine learning, AI in that. But anyway, we can just have a few words on AI also in this paper. Canon?
Actually, the rural definition and the rural communities are very different in different countries and regions. But somehow we see that the problems are nearly the same, and we can have nearly the same solutions. I want to highlight the telemedicine usage in rural areas. That's one of the solutions, I guess.
Okay. Miriam Dolan? Yeah.
Yeah, I agree with Canon. I think it is all about career pathways, exposure to more continuous professional development, and of course also that undergraduate exposure. Yeah.
Okay. Devanto?
Yes, thank you. I've given my points. Maybe I'll add a paragraph about psychological, cultural, and societal factors. Maybe at section 2 after limited capacity building and training in the manuscript. hopefully it won't add too much to the already long manuscript, but
You
okay,
can add
thank you.
just brief. You can add
Just a
briefly.
little bit. Okay.
Okay. Go with your final comments.
Yeah, actually, that I was not in the part of the paper others, but still I will be there and as a the panel one. Yeah, it was nicely given there all the topics and I think we have made it everything in the life cycle way from this training, strength training, even later on about this tension things and all. I think this is a good paper and we can present it in there as well with other colleagues. Thank you.
Okay. Azaz Khan.
Yeah, I would just suggest that if we are the solutions that we are going to put at the end, I think that those should be backed by evidence. So, for instance, if incentives are there, or retention is there, or South-South collaboration is there, so that should have some kind of strong evidence to make those recommendations or solutions. Despite that, whatever we have discussed, and it's an excellent paper, but there are a lot of references, and I think out of those which are coming from meta-analysis or systematic reviews, those should be given as a solution along with whatever we think. But those should be because those will be backed by the good evidence. Then whoever will be reading this paper will be convinced, or if it goes to the policymakers, at least they will have they will look they will have that high quality of evidence behind the solutions. Thank you.
Vikas, question.
Thank you. Thank you. This is very interesting discussion, and I really liked about it. And Nepal is also facing lots of challenges in retaining skilled human resources, especially doctors in rural areas. There's many articles published about retention of HR in rural areas in Nepal. One of many ways could be like continuing medical education and continuing to help upgrade the knowledge and skills of doctors working in rural areas. I think those articles can be valuable. So all of my colleagues who are working on this draft, please review those articles about rural retention in rural Nepal. Thank you, Pratyush.
Thank you. Thank you. Darshan Patil.
The main cause, what I somehow feel like for my age group, as I'm a final year MBBS student, so is that somehow the people who go abroad, like the brain drain, what you people are talking about, and go settle there, are considered somehow to be more successful. That's the mentality. That's what is going on over here. I don't know how it's correct or no. And even the pay scale definitely is higher over abroad than it's got compared to India. So as the competition is very high in India, like just for an MBBS graduate, the pay scale what we get over India and in other foreign countries, like suppose in UK or USA. So there's a very significant amount of difference for an undergraduate student. And again, post graduation is definitely again a different thing, but yes.
Okay. Itash Dwarka.
Yeah, I agree with a lot that is said, and it is extremely interesting. I think that from the paper's point of view, it is important to add, especially those few paragraphs. Otherwise, yeah.
Thank you. Dr. Anshu.
Uh, just 2 points. I think we need to rethink about the way we train our graduates and give them more community immersion experiences. And once they graduate, they will need supervision and support, whether you give it in the form of a senior being present there or through telemedicine. That depends, but they will need support when they're isolated. So that is important.
Thank you. We have got final comments from Yasashwi. Can you hear us? Dr. Darshana Salve.
So again, I would reiterate on the professional development facilities for the doctors. Yeah, and the rest we have already covered. Again, reiterating on the telemedicine part as well. It was quite doable, and when the resources, manpower is less, we can, take advantage of telemedicine services. Yeah, so I think that will be from my side. Thank you.
Thank you, everyone. And just an important announcement that during this Global Rural Health Summit, we're also going to have a new committee for new executive committee for the Wonka Rural South Asia. We are going to have an election for Wonka Rural South Asia, and we are going to invite nominations from all the South Asian countries. I have been chair for quite a long period of time, and it's time for me to say step down and have a new, bright, bold executive team from South Asia for the Wonka Rural South Asia. And we're also having a new team from India also, that is called as AFPI Rural, which is the Academy of Family Physicians of India Rural Chapter. It's a working party for the Academy of Family Physicians India. For that also, I have been the chair, and I'll be stepping down, and the new executive committee will be taking the charge of the rural part. So this is the rural developments which is going to happen in India and in South Asia on the Global Rural Health Summit. And most likely we'll be having a hybrid mode of this conference. And if it's if all the items have been done, then we will be sending you the notifications and the email to join you online if you're not able to join physically. So thank you all for joining this webinar, and it's been a really very interesting discussion, and I really loved. It's like a de-stressing moment for me organizing this webinar and listening to all your comments. Thank you all for joining this webinar. Thank you.
Thank you very much.
Thank you.
Thank you.
Bye-bye.
Thank you.
Thank you.
Good night. Thank you.
Yeah.
Yeah.
Bye-bye.